Hello everyone, I'm Ginny Lobel with Defined Health and we welcome you to today's edition of Defined Health's Insight Series webinars. Today's webinar is entitled Supportive Neurology, Valuing Increased Function and Improved Quality of Life in Treatment of Non-Core Symptoms of Neurological Disease. Today's event features a discussion moderated by Ginger Johnson of Defined Health with Todd Scherer, CEO of the Michael J. Fox Foundation for Parkinson's Research. Defined Health is pleased to bring you our Insight Series webinars as a way of showcasing how we think about and view, looking forward, various critically relevant topics for the biopharmaceutical industry complex. Our viewpoint is the result of our 25+ years of experience consulting with hundreds of pharma, specialty pharma, biotech, and investor clients. In these engagements, we bring our unique perspective grown over decades of evaluating pipeline and inline opportunities by bridging our knowledge of drug development, business development, and commercial strategy across multiple therapeutic categories and technology platforms. I just want to call your attention quickly to two of our in-person events happening in 2017. We'll present the 28th Annual Cancer Progress Conference in New York on March 7th and 8th. You can visit our website, cancerprogressbybh.com, to view the outstanding program, which includes world-class oncology luminaries from academia and all walks of industry, clinicians, pharma, biotech, diagnostics, big data, payers, regulators, advocacy groups, not-for-profit funding organizations, and other investors. And on March 20th to 22nd in Barcelona, Spain, we'll be presenting Therapeutic Insight by Defined Health at the EBD Group's Bio Europe Spring Partnering Conference. To learn more about Defined Health, our capabilities, and our upcoming conferences, please visit our website, definedhealth.com, or send us an email or give us a call. We'll be happy to tell you more. Quickly, housekeeping, assuming at the end of this permission from Dr. Scherer post the discussion, the audiovisual and PDF version of the program will be available on our website. We will notify you when they're posted. We hope to have questions. Time for questions at the end of the discussion. Please send them along through the webinar system as you think of them. If we don't get to them in this hour, we'll follow up with you directly in the next day or so. Thank you and enjoy this Insight Series webinar. I will turn it over to Ginger Johnson, Vice President of Defined Health, for a brief introduction of the topic.
Thank you, Ginny. So hello everyone, and thank you for joining us for this webinar. It's a topic that we consider very important for the biopharmaceutical industry and for the patients most importantly. So I want to start with about 10-minute introduction to define the context. What are we talking about when we say supportive neurology, talk through some of the unmet need, and look at some examples of clinical and commercial successes. Then we'll jump into a discussion with Todd Scherer, again, CEO of the Michael J. Fox Foundation, to drill further into the need associated with supportive neurology and advances to address this need specific to Parkinson's, but we'll also make some parallels with other neurologic diseases. So I first gave a webinar on this subject in 2008, and as I revisited, I didn't realize it was so long ago, but as I revisited the subject, I was happy to see that there have been a lot of advancements, a lot of activity in terms of basic research, clinical research, and new product approvals. The concept is the recognition, diagnosis, and treatment of conditions beyond those central to and/or diagnostic of the neurological disorder. These symptoms range from those that are known to or thought to be directly related to the disease itself. An example may be something like sleep disturbance in Parkinson's disease. We'll spend some time with this later, but Parkinson's patients experience a loss of orexinergic neurons, loss of dopaminergic neurons, causing excessive fatigue, and this fatigue or somnolence can also be worsened by Parkinson's dopaminergic medications such as the dopamine agonist, so that's treatment-related symptoms. And then the third category is comorbid symptoms, not directly associated with biology of the disease, but commonly occur in these patients, and perhaps anxiety might fit into this category. The lines are not clean. We're still getting a good understanding of distinction and overlap. So that's, again, we'll drill down further into that. Let's look at some of the conditions in particular. So starting with multiple sclerosis, which, you might argue has one of the most advanced standard of care of all the neurological conditions, and that we have multiple disease-modifying therapies, at least for the relapsing remitting form of the disease. It's still associated with a host of symptoms that are not motor-related, but nonetheless have a major impact on the patient's function, ability to work, activities of daily living, and quality of life. You see some of those in the box on the slide, and you also see some common themes as we go through these in terms of some conditions that are common across multiple neurological conditions, things like fatigue, cognitive dysfunction, depression, anxiety, and pain. So as we move on to Alzheimer's disease, for the 5 million or so patients just in the U.S., the symptoms distinct from dementia include things like depression, apathy, anxiety, and agitation or aggression. And depending on the stage of the disease, these symptoms can be even more of a burden to the patient and or the caregiver than the cognitive dysfunction. Behavioral disturbance may be an example in that it's associated or has been shown to be associated with a more rapid cognitive decline in Alzheimer's patients, a higher rate of institutionalization, and increased caregiver burden, and a higher cost of care. If we look at Parkinson's disease, supportive neurology indications associated range from things like a loss of smell and taste, which can lead to loss of appetite, weight loss, frailty, down the line complications, psychiatric symptoms such as cognitive dysfunction and psychosis. Sleep disturbance is a very interesting category we can talk more about, and autonomic disturbance such as incontinence and constipation. So as therapy and standard of care for core symptoms of disease conditions improve, and it has been, patients still let us know loud and clear, and we also hear from the physicians that we at Define Health talk to on a regular basis that the non-core symptoms continue to be real problems that are not being addressed. And here are just a few quotes from patients that are clustered around the common symptoms of fatigue, cognitive dysfunction, and psychosis or agitation. I won't read them. I'll let you look for a second. They're very compelling. So over the past several years, we've certainly seen an increased interest in supportive neurology and some real advancements, which I think are driven by a few factors, which include a continued unmet need, an advancing understanding of symptom characteristics and underlying biology, an improved clinical probability of success due to things like recognition and diagnosis of the symptoms, the ability to identify target responders, the ability to measure the effect on that symptom in clinical trials, and more, which we'll discuss. An expanding support structure, a friendly regulatory agency, patient advocacy groups, non-dilutive funding, and an emerging pipeline, which also provides interest from potential partners and additional funding, and importantly, commercial and clinical successes that provide value to address issues that are unique to the neurological condition, which is an important distinction. One high-profile clinical success, or recent clinical success, is Acadia's Nuplazid, which is pimavanserin, which was approved in May of this year for the treatment of Parkinson's disease psychosis, or PDP. And the regulatory authorities recognized the need that this agent promises to address and granted it breakthrough designation, which resulted in approval in under 8 months with only one phase 3 pivotal study. They used a scale to assess positive symptoms in Parkinson's disease patients, which is a standard, old scale that was adopted for Parkinson's. And the secondary endpoint assessed the motor function in the Parkinson's patient using the UPDRS 2 and 3. So what you get is Nuplazid provides efficacy for the treatment of PDP, comparable or maybe even better than, hard to tell because they're not head-to-head studies, the standard of care, which is antipsychotics, but without an increase in motor symptoms, which is of particular importance to the Parkinson's patient. So this profile was achieved by selectively binding to the serotonin 5-HT2A receptor by having minimal affinity for the slew of other neurotransmitters that the typical or atypical antipsychotic modulates to various extents. And again, without affecting the PD symptoms. It does, however, remain to have the black box warning of the antipsychotics, which is increased mortality in elderly patients with dementia-related psychosis. Pimavanserin, or Nuplazid, is also expected to be a commercial success, with analysts forecasting sales of over $1 billion for just the PDP indication, increasing with additional indications in AD psychosis and schizophrenia. It's important to note the price tag there goes well over the rule of thumb, which is under $600 a month to minimize payer access restrictions and avoid being put on a specialty tier. So it will be interesting to see how this rolls out. Nuplazid joined a small but growing club of commercial successes in supportive neurology. These are just two. The first is Nuedexta, which is a combination of two agents launched in 2011 for the treatment of pseudobulbar effect, which is uncontrolled outbursts of laughing and crying or crying associated with multiple neurological conditions, and peak sales are expected to reach about $600 million in the U.S. And then Northera, which is droxidopa, synthetic amino acid analog that's directly metabolized to norepinephrine. It was launched in 2014, and it's indicated for neurogenic hypotension, which is again associated with multiple neurological conditions, including Parkinson's disease. And finally, there are multiple agents in the pipeline. These are examples of a few. And so we have AVP 786 is really next generation Nuedexta for AD agitation, SRX 246 for irritability and Huntington's disease, tirasemtiv, which is a very interesting story, ALS respiratory function. They just did a deal with Astellas for this program, SYN120, Acorda Biotie's phase 2A agents for PD dementia, and nelotensrin, which is Axovant's agent in development for visual hallucinations and REM sleep behavior disorder in Lewy Body Dementia and Parkinson's disease. And again, we will go into detail on these with Todd. So with that, let me introduce Todd Scher, CEO of Michael J. Fox Foundation. He's formally trained as a neuroscientist. He directs the foundation's research strategy and is responsible for overall scientific and fundraising direction. So I have a few slides just to prompt us as we go through the questions, but on this slide, PD is a constellation of symptoms. This is taken right from the Michael J. Fox website, and this is what they show to their patients. Characterized at a high level as motor symptoms of Parkinson's and non-motor symptoms. So Todd, can you start by discussing the broad spectrum of PD symptoms and the role of non-motor symptoms on patient function and quality of life, and expand a little on which are the most troubling and how might this change over time and or with progression of the disease?
Sure, great. Thanks, Jinjin. I'm really glad that you're taking this as a topic for discussion, because I think for many years the non-motor symptoms of these diseases have been appreciated and haven't received the necessary research attention given the impact they have on patients and the quality of life of patients and their families and caregivers. Parkinson's, as many people know, has historically been viewed as a motor disease, slowness of movement, rigidity, tremor, and many of those symptoms and aspects of those symptoms are due to loss of dopamine in the brain, which has led to very significant symptomatic treatments that have great benefit for patients in dopamine, starting with Sinemet as the levodopa precursor, but then dopamine agonists and other compounds that can prevent the breakdown of dopamine in the brain. And I think what we've been learning more and more, and I would say this really was driven by the patients as well as the interactions with their clinicians, is as we've gotten better and better at moderating some of the motor symptoms, the aspects of the disease that are most impacting people's quality of life really are many of the non-motor symptoms of the disease, which still don't have very effective treatments. I think significantly in Parkinson's, things like cognitive impairment, which can be occurs very early in the disease as aspects of executive dysfunction and decision-making, and progress throughout the disease in many cases even all the way to dementia. This is an area that is very significant for patients, really impacts quality of life, impacts their ability to continue to work. And many of these other symptoms that are listed here are also can impact a wide variety of patients. Depression can be common, anxiety, very significant sleep disorders where people are up at night, sleeping during the day. Constipation is something that's reported as a very significant impact on quality of life by patients. And I think what's important also is that these symptoms are not individualized. They do happen in constellation in individuals. So there are people that are managing an array of these symptoms as well as their motor symptoms during the course of their disease. And that results right now with very much a constellation of different treatments as we try to address each of these symptoms one at a time. And there is great overlap and interaction of these treatments that can also cause unintended side effects as well.
Thank you. So we'll get into some detail on these. I want to, something that you said at the very onset was attention to the space. A lot of it has come from the patient, and so the voice of the patient exercise with the FDA and the public meeting in September of last year focused on Parkinson's disease. Can you talk a little bit about that, the role of Michael J. Fox there, and what you heard from the patient?
Yeah, I mean, this was a really interesting opportunity being led by the FDA to really hear directly from patients and what's impacting their lives and what really should be the focus of some of the new treatments. And I should point out we obviously all desperately want to have a disease-modifying treatment that could slow the disease progression, maybe even prevent it. But I think in the interim, there's great need that was voiced at this meeting from the patient community about the limitations of the current treatments and what really are aspects of the disease that are significantly impacting their lives. And for example, even in the management of the motor symptoms of the disease, as the disease progresses, there still are real challenges with motor fluctuations, periods of on and offs where the drugs are working, and some of the side effects of these medications that could lead to dyskinesias for increased movement, as well as some of the side effects of dopamine agonists that could lead to compulsive disorder. So this is an area that still needs, from the patient perspective, some real work, which is better motor management. But what you really heard from this meeting were some of the aspects of the disease that are significantly impacting the quality of life of patients: cognitive dysfunction, falls, constipation, sleep problems. These are very significant, undertreated, poor treatments today, and really have a great opportunity where if we can make breakthroughs to really have a significant impact on the ability of people to live with Parkinson's disease. Another thing I would say that came out of this meeting, and this is sort of a common statement that comes from clinicians who treat Parkinson's, is that when you treat one Parkinson's, if you treated one Parkinson's patient, you've treated one Parkinson's patient. There is great variability and heterogeneity in the severity of these symptoms. When in the disease course, they really come on for different individuals. And I do think that is one of the challenges that we need to think about in terms of selecting patients that may best benefit from some of the new treatments being developed.
Thank you. I want to spend a bit of time on this slide because I think it's really important that we discuss supportive neurology as adding unique value within the context of the underlying neurological condition. So, for example, treating a Parkinson's patient with sleep dysfunction requires a different therapy than treating a non-Parkinson's patient. And same thing for, treating cognition in a Parkinson's patient is different than, or the need is different than what you might need in an Alzheimer's patient. You said Parkinson's patients have difficulty with executive function. Alzheimer's is more about memory. And I think there are lots of examples, and which, points to the value, the unique value for these patients. So maybe let's talk about some of those symptoms that are really related to the disease itself. Sleep is one that is getting a lot of attention for multiple reasons. For the REM disorder, for the sleep that's associated with the symptoms of with the treatment and how that exacerbates, and even, go further and talk about sleep as a way to identify prodromal patients. So I know that's a mouthful, so turn it to you.
So I guess I'll start with the sleep example and then make some other comments based on how you frame that. So even sleep disorder in Parkinson's is many things. As you mentioned, there is another disease called REM behavioral disorder, and people who have REM behavioral disorder actually have an increased risk of developing Parkinson's. It's believed that, a theory, at least a hypothesis, that an alpha-synuclein pathology may underlie both of these disorders. But we have run some studies now where we've looked at people and examined them who have REM behavioral disorder, and you actually can identify people using a dopamine scan, the DAT scan in the brain, which are people who have REM behavioral disorder and are already showing loss of dopamine cells in the brain, and those people are very likely to then convert to becoming people with Parkinson's disease as defined by the motor symptoms. But then also people who have Parkinson's disease can have an array of sleep disorder symptoms. As I mentioned, they can be up at night, have trouble getting to sleep, and then they have daytime sleepiness as well. And it is not always clear, in this case, even as an example, of which exactly aspects of these symptoms are innate to the disease versus which are exacerbated or a response to the treatment, because particularly in Parkinson's, once people are a few years into the disease, they all will begin some type of treatment regimen. So but it's a very significant symptom because, a lot of these symptoms we mentioned and the non-motor symptoms are all related, as we know from literature outside of Parkinson's disease, that sleep can impact cognition and mood and vice versa. So there can become a spiraling effect in these patients. A couple of other comments I think that are relevant in terms of thinking about developing treatments for these symptoms. One is really understanding and trying to get more insight into what might be the molecular mechanisms or the neurotransmitter mechanisms for the particular symptom in the context of the disease. So it's not only that the symptom may appear different, the underlying biology may be different. So it may not be that you can just obviously transfer treatment for sleep disorder right into sleep disorder in Parkinson's. But I think the other point that's very important, which is the one that you highlighted in the Nuplazid example, is that one of the main points of new treatments would be to do no harm and need to make sure that in treating the new symptom, we're not exacerbating or preventing the impact of the motor treatment in the disease. So in atypical antipsychotics, most of those would function by having at least some component that blocks dopamine signaling. obviously you don't want to block dopamine signaling in someone with Parkinson's disease. So that's where you did need the new innovation of a treatment. So I think in this regard, it really makes it important as developing these treatments in the clinical testing to make sure you're always assessing the fundamental symptoms of the disease as well as the new symptom that's of interest.
Thank you. So you mentioned constipation before. It's interesting in that you can tell me, but I think it's somewhat inherent to the disease, the slowed colonic transit time, the muscle rigidity, just the symptoms of Parkinson's itself contribute to that. So treatment may need to be unique for these patients, and then it may also have an effect just on other therapies overall, and that you're just delaying that gastric emptying, I guess.
Yeah, so this is actually, it's not even theoretical what you said. That's actually in practice what the situation is. So first, for constipation in Parkinson's, the exact underlying cause mechanism is not known, but we do know that, again, the alpha-synuclein aggregation and pathology that's seen in the brains of Parkinson's patients is also seen in the nervous system that innervates and controls the gut. So there could be a common biological pathway that's resulting in the symptoms. And it's also believed that some of these changes in the gut and digestive system are very early in the disease. So that's, it's innate to the disease what's sort of going on in that system. But we do know already that this now compounds the effectiveness of the dopamine-based treatments, particularly Sinemet, which has or levodopa, which has a very unique absorption profile in the digestive system in terms of how it gets into the blood. And patients really have to be careful with their diet as it relates to the timing and taking of the medication. And they can have these drug failures. They take a pill and it just doesn't kick in that maybe relate to some of the digestive and handling of the medicine. So this really is significant in a number of ways to the patients. First just the discomfort around the symptom of constipation itself, but then how that may compound the effectiveness of the other medication that they're counting on during the course of the day.
Right, and it just further complicates a very complicated treatment and adherence for the patient.
Yep.
I thought I was going to ask something that, while we're talking about constipation, this is off topic, but what about the role of the microbiome? Is there research going on there, since you see the microbiome has potential to address anything and everything? I'm assuming there's some work in Parkinson's too.
Yeah, definitely is, and I think particularly what's of interest in sort of some of the I would say early intervention type of approaches is really thinking about some of the early symptoms of Parkinson's. Could be these digestive problems as well as smell loss, which I know smell loss is also common among other neurodegenerative diseases. But Parkinson's, idiopathic Parkinson's, the more garden variety form of Parkinson's, is believed to be due to sort of an interaction between the environment and genetics, which of course basically means we don't know what causes it, because what isn't the result of an interaction of environment and genetics. But two of the nexus where that interaction may happen is in the gut and in olfactory system. So I think there's more recently been a lot of focus on this to try to understand what might be that interaction between environmental exposures and sort of the home host environment, the person, their genetics, and other components such as microbiome that might initiate a cascade leading to a neurodegenerative disease, similar to interest that's going on as well in the immune system, again, being that interaction between the environment and the genetic makeup of the individual.
Okay. So, with these more attention and incorporation in just defining the patient or characterizing the Parkinson's patient, are you seeing a changing definition of the disease? Like, for example, Huntington's disease is characterized or defined as a triad of motor, cognitive, and behavioral symptoms. Are you starting to rethink what is Parkinson's?
Yeah, this is really a very active area now, and particularly at really redefining or rethinking what does it mean to when you would have the diagnosis of Parkinson's. So given the example I just gave you with REM behavioral disorder, so if you have REM behavioral disorder and a detectable loss of dopamine function in your brain by a dopamine scan, and let's just say that person also had constipation and depression, but they did not show a motor symptom yet, there is an ongoing debate to say, does that person already have Parkinson's disease, but they just haven't reflected that in their motor symptoms yet? And that's because we do know from research that the loss of dopamine and the pathway begins well before that first tremor has been detected. So this really, I would, active debate in terms of really trying to push the clock back earlier as you're looking into disease-modifying type of therapies.
That's very interesting. So it's not just identifying what's prodromal. They may not even be prodromal. As you said, they may be the earliest stage Parkinson's patients.
Right. So there's a debate now about whether you call it prodromal or premotor Parkinson's. But this is, that might be if you had a real disease-modifying type of approach, maybe these are the type of people ideally you would ultimately apply that treatment to, and they never go on to have a motor symptom.
Very interesting. Before I go to the next slide, anything else you want to touch on with this one?
Let me see. Not really. I mean, I think that one thing which I think we're going to get to, which relates to sort of the uniqueness sometimes and sometimes the overlap of these symptoms with other diseases, really gets to the focus on measurement and making sure that the scales and approaches that are being used in the clinical testing accurately reflect the symptoms in the disease that are of interest. Again, that was built on the example you gave in Nuplazid, that they couldn't just take psychosis scale off the shelf and now say we're going to run a trial using that scale in Parkinson's. There was some work to fine-tune that scale to make sure you were actually measuring the relevant aspects of that symptom in the context of the disease that was of interest. So I think that's sort of a natural result of how you frame this with sort of the disease and treatment-related symptoms.
No, I think that's incredibly important, and it is one of the things that we identify to talk through, among other things that are, contributing to probability of success. That's defining an endpoint that's relevant to the patient population. Maybe, and I meant to put it on the slide, but I didn't. Why don't you talk about maybe the agents that are on the market? Two that I pulled up were Northera and what's the other one? Nuplazid. Thank you. Just your sense of the value of those for Parkinson's and for other neurologic conditions.
Yeah, so I guess there's a couple of points that I'd like to make in this context. So I think first, what's extremely exciting is that this isn't theoretical anymore. There actually are products that have made it through all the phases and through the FDA approval to address some of the previously untreated but significant symptoms for Parkinson's. And that's in Northera, there was the low blood pressure that people have in Parkinson's, which not only is the cardiovascular symptom significant, but this is a very significant risk factor for falls. The way that this is lightheadedness if someone stands up too quickly and you already have balance problems. So that can be a very significant problem for patients. And then, the hallucinations and psychosis is a very significant particularly in later stages of disease, leading to lack of independence and requirement for nursing home care. So I think the jury's still out to see, now these drugs are fairly new on the market, to see how well they address the symptom. So I think the other point, which is just the momentum that we're seeing in this, and the fact that we're getting these new treatments through, and something like Nuplazid that got breakthrough status and only needed one large trial shows that there's a real appreciation from the regulatory agency about the unmet need, and that we need to be open to innovation. So I think this is a really exciting time to have this discussion, because we actually see that there's great value and ability to develop those new treatments for patients that really could benefit from these innovations.
Yeah, I think I agree, and I think the approval of Nuplazid and watching it roll out into the market will be very telling. But I get the sense that the value proposition there in not exacerbating the motor symptoms is truly important, and perhaps it goes beyond that. Maybe you could talk about that a little bit, just the affinity for the 5-HT2A versus all of the other receptors that the antipsychotics hit, and how you think that will translate in the real world.
Yeah, so I think that it's, I think the data from the study is promising to show that they're having a meaningful effect for patients. And obviously for someone with a neurological disease who's taking other medication, the more selective you can have with your compounds, you hope the better, so that you have less interactions with other drugs. So I think there's great promise in what this could have, the benefit it could have for patients. Particularly, I would say, patients that previously didn't really have any other options. So even if it isn't a home run benefit, it's still going to be better than what was, hopefully better than what was previously offered. One other thing that I think is important to point out, particularly in the case of Nuplazid, is that previously I don't think a lot of attention was paid to the symptom in the clinical care of the disease. It's a difficult psychosis, a difficult symptom to identify and to assess, and there was no good treatment. So, some of the sense we got from the interactions with the thought leaders and even patients, that it wasn't something that was really discussed as a major component of the clinical exam. A lot of emphasis on motor symptoms, we could manage those. So I'm also hopeful that just the fact that we now have this drug on the market, it raises the awareness of this symptom and opens up the discussion, so perhaps there are even more people who are dealing with this that now have the potential to benefit.
That's interesting, and so increase awareness and hopefully treatment, you think, and perhaps even at earlier stages?
Yeah, I think that's, this is all conjecture, but I think without a great treatment, my sense is that this symptom only really got raised in the clinical exams when you couldn't ignore it anymore.
Yeah.
And now maybe, if we could develop ways to screen for it and put it in the minds of both the doctors and the patients, perhaps things could be identified earlier where you can get treatment earlier, and then more years of more higher quality of life because of the availability of the treatment.
Okay. Do you have a sense of treating, whether better treatment for something like, while we're on the subject, psychosis, and perhaps earlier in the course of the disease, will have an impact on overall outcome for the patient? So treating the supportive indications and that contribution to the overall outcome.
Yeah, I think it's hard to know. I mean, I guess I could come up with some reasons to support that. So none of the, like for example, I don't think there's any evidence just to state that a 5-HT2A drug is disease modifying, that it's saving cells. But I think if you think of things like something that might treat sleep or depression, and as a side effect, people's cognition get better, there are other quality of life things that people with Parkinson's disease can be doing that we do think impacts the outcomes as well. Things like exercise and being socially engaged and other non-medical interventions, quote-unquote interventions, that there is fairly good evidence can benefit people in the long term. Because all these symptoms are interrelated, I do think there's the possibility that you can have this more holistic, longer-term benefit even if you're addressing one of these individual symptoms with the disease. Now that I think is to be shown, but one of the things I think that's important when you think about developing treatments for these symptoms is make sure that we're not only assessing just this symptom on a scale, but we are getting a sense of the holistic quality of life or functionality of the patient, because not only is that where the big bang is, but you may uncover a very positive surprise that you didn't anticipate.
Yeah. So let's talk about some of these agents on this slide. Maybe jump to Axovant's drug, neurological, because it's the same mechanism as Nuplazid, which we've been talking about. Oh, maybe a little bit different and nuanced, but essentially the same. So talk about that and how they've chosen visual hallucinations in REM sleep behavior disorder and Lewy Body Dementia first, and then going to...
Yeah, so first you're trying to catch me up on my poor score in clinical pharmacology on the difference between an agonist. So I'll save that to get you later on that one.
All right.
I mean, I think, so I think that, so in the serotonin system in general, there actually is a lot of evidence that targeting this neurotransmitter system could be a potential benefit for an array of symptoms in Parkinson's. These include actually even some of the motor symptoms, in that as there's some evidence to suggest that as you lose dopaminergic terminals, that the serotonergic terminals can take up the levodopa as a false transmitter, and then by kind of controlling the activity of the serotonin, the serotonergic terminals, you could actually get rid of some of the side effects of the dopamine treatments. So I think there's great broad interest and applicability in this area. So clearly the hallucinations is a symptom that there's proof of concept in through some of the work from the Acadia group. I'm not, as positive about the evidence around why they chose the REM sleep disorder, again, but there is some data suggesting a link of this transmitter system impacting that symptom as well. And Lewy Body Dementia is a very significant Parkinsonism, and these symptoms are very common and debilitating in that disease.
Okay. So maybe let's move to the Acorda Biotie. I forgot to put the mechanism on there. It's a 5-HT2, again, 5-HT6 dual mechanism. So a lot going on with serotonin here. But they're looking at Parkinson's dementia. Can you talk just about, I know you touched on it before, but again about the dementia in Parkinson's patients and the promise of this compound?
Yeah, so this is actually one that the Fox Foundation has supported, just for the declaration on that one. So it went through our panel. And Parkinson's dementia is a very, very significant symptom. Is obviously the most extreme aspect of the cognitive dysfunction in Parkinson's. And there is actually an approved drug for Parkinson's dementia. It's one of the Alzheimer's drugs that's just been repositioned. So there's also an FDA path. for that. And there has been a lot of debate, and I'm sure it's very similar to the Alzheimer's debate about, where do you start your evaluation? Do you look for more of the mild cognitive impairments in Parkinson's, or start with doing a symptomatic study in dementia? And that's, in this case, it's a much more straightforward path. Very interesting preclinical data around this compound, as well as some of the early clinical evaluations that they have been conducting. So this is one that we're particularly following and interested in.
So, you talked about the clinical endpoints and with Nuplazid and adjusting the positive score that's used for schizophrenia patients. And I might be wrong, but I think I remember that Axovant patch, right, that's indicated for Parkinson's dementia, that they used the Alzheimer's ADAS cog endpoint, but not so with the SYN120. Can you talk a little bit about that endpoint?
Yeah, so this is a major, actually the foundation's involved in this, working with the Movement Disorder Society, and there's a major effort in terms of developing and validating the appropriate cognitive endpoints in Parkinson's disease, both for the mild cognitive impairment and also to just confirm around even the significant cognitive impairment leading to dementia. Mm-hmm. And also being able to link cognitive function to functional outcome and functional impairment in Parkinson's. So we actually have worked with the Movement Disorder Society and hosted a meeting about 1.5 years ago, 2 years ago with FDA to really dig into this topic, to really try to develop sensitive scales for Parkinson's, mild cognitive impairment in Parkinson's, and how those relate to the scales that we use for Parkinson's dementia. So I think this is an evolving field. It's been a number of years since the trial was done for Axovant, and there's a much greater appreciation of sort of the holistic aspects of the symptoms that could contribute to Parkinson's dementia. So I think what they're working now is to sort of reflect some of this new knowledge in the new trial.
Oh, that's very interesting. Before I go on to the next slide, anything else on this one you want to touch on, or any other agents in development that are not on this slide? Not to go through sort of a whole list, the only thing I would say is that this is an area where if you looked 5 years ago, at least in non-motor symptoms in Parkinson's, and compared it to today, there's a very significant and robust pipeline of therapies that are now being developed, including, I mentioned this, I guess, earlier, including new treatments for even some of the improved treatments for some of the motor symptoms to modify and reduce motor fluctuations, to have more consistent. These are mostly delivery approaches to try to deliver the treatment better, the treatments better. So this is, an area for symptomatic treatment in Parkinson's where there's still great need and great opportunity. Okay, which is very encouraging, and just looking from the outside, it looks as if there's a lot of activity in Parkinson's disease in particular, but we're seeing it with the other neurological conditions, and then we're seeing certainly starting with one neurological condition and then follow-on indications for others where it makes sense. So maybe I'll go to the next. And this is just a list of questions. Actually, this is my last slide, I believe, of things that we might want to touch on with our last 9 minutes. That first question is big, and you've really described it already, what makes a product viable from a standpoint, which is a lot of the reasons that our clients come to us. But just reiterate, what is it that you're looking for? What is it the patient's looking for, the clinicians are looking for? And lastly, do you have a sense of what the payers are looking for and
of life and the functionality of the patient. You know, an individual patient has an array of these symptoms. So it's not so much did we improve someone on a scale, you know, an anxiety scale or an apathy scale, but how did that sort of impact the holistic person? And, you know, that's what a lot of the work now in terms of a lot of the scales, they even updated a couple of years ago, the Movement Disorder Society updated the UPDRS, which is the common scale for Parkinson's, to have more of a reflection on non-motor symptoms and a holistic assessment of the person with the disease. So I think that is probably, you know, one of the most significant things to make sure is built in, and there are ways, you know, to do that. The other point I was just thinking to make is that, you know, we referred to this earlier in the call, that now that we're, you know, 20, 30 years later, managing the motor symptoms of the disease a lot better, not perfect, but a lot better. And with people being diagnosed, in the case of Parkinson's, in their mid-50s, people are living 20, 30 years with the disease. And any of those years, the most significant things they're dealing with are the non-motor symptoms. Yeah. Because early in the disease, we're managing the motor symptoms reasonably well. And even in later disease, many patients go on and get deep brain stimulation. Deep brain stimulation targets the same symptoms as the dopamine treatments. So it's not only a significant issue, you know, in a list, and say 25% of patients have this or that. This is really the largest component of the disease that's untreated. So when we bring our patients together and you say, what would you like in a new treatment? Just to be clear, the first thing they all say is disease modifying. If I could stay as I was the day I was diagnosed, I could live with that. In lieu of that, these areas around the non-motor symptoms are the remaining biggest unmet need for these individuals with the disease.
And that goes across, you know, some of these diseases. One that I think it's similar is MS, in that the patients are diagnosed very early, and they're, you know, mostly women at an age where they might have young kids. They're very active. Their motor symptoms may not be, you know, terrible at that point, but they have symptoms such as fatigue and even starting to have cognitive dysfunction that are, you know, incredibly troubling and impact all the things we've been talking, you know, their ability to go to work or do whatever it is they need to do every day. So I'm glad this is getting a lot of attention. So you didn't talk about the payers. So they generally don't get too excited about quality of life.
Yeah, I mean, our sense, we had a couple of meetings where we brought in payers, and our sense, at least at this stage, is they weren't really paying that much attention to Parkinson's disease. It wasn't really a major.
Not on their radar.
Yeah, so I think, you know, as more of these drugs come out, and, you know, one of the issues I think we face more with Parkinson's right now is you have Sinemet being a generic. When you have a new motor symptom treatment, that one really has there's a burden on them to really demonstrate why is that, why should there be a premium paid for this versus the generic Sinemet. It'll be very interesting, like you said, to see what happens with something like Nuplazid. That's a first-in-class and first, you know, for this disease mechanism, you know, disease symptom, and how that is handled, because there really aren't any other approved options.
Okay. And just so you know, that last few questions that I had, I incorporated some that we're getting in from the audience. So we've got like 5 minutes. There's two big questions, and 5 minutes is not going to do it. But one is, you know, I'm saying there's an increased probability of success in this field, or increasing probability of clinical success, and a lot of things that are contributing to that. Can you, you know, do you agree with that? And what is it that you think is making contributions? And one of the things I left off of that list in the parentheses is biomarkers?
Yeah, I think there is definitely an increased probability of success in this area because that's what we've actually seen. So there's been success. So that's, you know, and I think it is a lot of the factors you're saying. There's an increased understanding of the disease and the targets, increased appreciation of these symptoms and how to measure them, and the clinicians are engaged in that process. So there's a great effort from the movement disorder experts on these non-motor symptoms because it's what they're dealing with on a daily basis. There's also been the foundation and others have made a very significant investment in natural history studies of the disease. So there's increased understanding now of when these symptoms are coming on, in what percentage of people, which ones seem to come on together in the same individual. So just a really increased baseline of knowledge that we're building off of. And you know, as we referenced, even now with an openness from the regulatory agencies to think about these symptoms in unique ways. So I think the ecosystem is poised, you know, to have even more breakthroughs coming forward in the next few years.
Yeah, I think I absolutely agree, and that's great. And I know maybe we, in the last few minutes, roll those next two bullet points together in, you know, from your experience, any advice to companies that are looking in this space, and what's the role of your foundation, as well as other advocacy groups in advancing what we're calling supportive neurology?
Yeah, so I guess I'll take the one about the foundations first. So, you know, Fox Foundation as an example, but there are foundations in, you know, National MS Society, there's a Huntington's organization that's similar, the Alzheimer's Association. So there's a couple of roles. There's funding. You know, foundations are interested in high-risk projects that will impact the disease population that they're working on, particularly symptoms that are very significant impact on their quality of life of the patients. So that's one area. I think the other that could be equally important is the access to patient populations, patient opinions. So, you know, we also do efforts, and many of these others, in terms of engaging patients in clinical research, surveying patients, developing scales. So there's things foundations are working on that are across individual, you know, that go across therapeutic programs. You know, we have a big investment in biomarkers and clinical scale development to help all people working in certain areas. So the advice that I have for companies would be, one, I would suggest try to engage with those foundations because there's going to be information and resources that they have access to that may be difficult for you to get to. But I also think, you know, some of the other things we've touched on this call around measurement, making sure that you make an investment early in your programs to understand what those measurements will be in the trials that are relevant for where you're going, and many of those can be developed in collaborative ways, and it's better almost if they're developed in collaborative ways. So I think that, you know, again, there's a lot of resources on top of sort of the scientific opportunities that make this a good time to pursue this area of inquiry.
Great. So, your foundation certainly is focused on Parkinson's disease, also Lewy Body Dementia because it's so tightly associated. How do you deal with, you know, other neurological conditions, or do you work with other foundations?
Yeah, so one interesting example of what we've done in this recently is we actually have, in the area of biomarkers, have had a running program that is a collaboration between Parkinson's and Alzheimer's foundations, really looking at some of the underlying biomarkers. And it's sort of an interesting way to think about things that we historically have defined these diseases more strictly clinically, like you have Parkinson's disease dementia, or you have frontal temporal dementia, or Alzheimer's dementia. But we're finding for biomarkers that there's great overlap between some of the underlying biology. For example, many Parkinson's patients will have amyloid biomarkers showing up in their spinal fluid, and Alzheimer's patients, a subset, will have dopamine dysfunction and synucleinopathies. So it's a collaboration across the diseases to try to see, perhaps in the future, many years in the future, we would segment these populations differently and target the therapies based on what we're seeing in the biomarkers. So that's kind of a new area that we've been collaborating on.
That's great to hear about the collaboration. And so thank you so much, Todd, for your time. This has been really informative, and I hope so too for our audience. Before we sign off, any last comments?
Just again, wanted to thank you for bringing this topic to the attention of the group, and hope if anyone is interested in Parkinson's to contact the foundation, and we'd be happy to talk to you about that in more detail.
Okay. Thank you so much again, and thank you everyone for joining. Have a good day.